Good afternoon, everyone, and welcome back to our Department of Medicine annual lecture. Today, we have our lecture starting under Medical Oncology Department. This will be a series of 4 lectures under them, and first will be by Dr. Ajoy Oommen John. Sir is assistant physician in the Department of Medical Oncology. Sir's field of interest is including clinical and translational oncology, communication, and medical education. He has various publications under him, and then he is on having his topic today for approach to breast malignancy. So, if any questions through the lecture, please feel free to ask Sir directly, or maybe you can put down in your chat box. This lecture will soon be uploaded on our Department of Medicine YouTube website. So, if thanks a lot, sir, for agreeing to take this lecture for us, and over to you, sir. Thank you.
Hi, good evening, everyone. So I'm going to be talking broadly on the role of systemic therapy, chemotherapy, hormones, and targeted therapy in breast cancer. So just a brief outline of what I'll be speaking on. I'll be talking about an evolving understanding of what breast cancer is, what translational research has happened, what are our current standard definitions for treatment planning, and applying trials to the individual patient. And I'll also kind of divide how we approach in the clinic, that is as early breast cancer, locally advanced breast cancer, and metastatic breast cancer. So there has been a lot of change in the 1980s to the 2000s. The difference and time taken for translation of basic research to clinical research was long, arduous, and the bridge was just being built. But now we have, in the last 20 years, come to a stage where we are able to predict cancer aggressiveness with basic science research and very rapidly translate that into clinical research with changes in clinical management happening very rapidly. So this is what a tumor cell looked like in the 70s according to our understanding of how the tumor cell was. And this is what a tumor cell looks like after the 2000s. So as you can see, there has been so much of advances in the understanding of how malignancies work and what are the different targets and pathways involved in cancer. We've also had successful revolutions in the field in terms of understanding how the tumors are so complex in not just their gene expression, but even the silencing and way the proteomics work. So I'll broadly divide our systemic therapy approaches into chemotherapy, which is synonymous with almost like a bomb, endocrine therapy and anti-HER2 therapy, which are like this. And although it's not in the slide, the newest entrant to this armamentarium is immunotherapy, which I think of like a spy because you induce your own immune response against the cancer. So the two main questions that need to be answered when we're thinking about treating breast cancer patients. One is, who are the patients who need treatment? And in that way, we have to understand how to avoid over and under treatment, and which treatment is best for that patient, and individualize the treatment. And towards that end, we need to have good prognostic and predictive factors, and that's some of the things that I'll be talking about now. So our understanding of breast cancer basically starts from the early 2000s, where multi-gene array studies divided breast cancer into multiple subtypes. And so we have now come to the understanding that breast cancer is not a single disease, but actually a collection of multiple diseases. So, yeah. So you can see here, the one way to approach breast cancer is to look at these subtypes. And we can broadly classify them as luminal, which is further classified as luminal A and luminal B. Then there's the HER2 enriched type. Then this normal like is a controversial topic because it looks like normal breast tissue, but we don't know if it is an actual breast subtype or just normal breast tissue that got contaminated in the biopsy sample. That bit is controversial, but we'll omit that. So you have a luminal, which has luminal A and luminal B. Then you have the HER2 enriched type, and then you have basal. And this is the overall classification of breast cancer. But you must remember that doing these sort of gene arrays in a clinic is not feasible. These are all very much in the research domain. So one way of classifying that we look at is to divide them as hormone receptor positive or luminal like, and then a receptor negative. And then further subdivisions came when we found that the luminal A group, the luminal group itself, like I said, there's a luminal A and a luminal B. Now, what is luminal A? Luminal A means they are patients who have a very high ER expression and have a very low proliferative index and usually are HER2 negative. Okay. Now, in my next slide, I'll show you why this is important. The second difference that you have to make is it luminal B? Now, what is luminal B? Luminal B means the ER expression is not as high as the luminal A. They tend to be lower. They have a higher proliferative index, and they can be HER2 negative or positive, variable HER2. So luminal B is like an in-between. So when you think about breast cancer, we think of it as the luminal A or ER positive, which is an approximation to luminal A, right? Then you have the triple negative, you have the HER2 positives and the ER positives. So this group is the luminal B, which is a mixed group. So therefore, like I said, the importance of this classification comes in the prognosis. So you can see the luminal A subgroup, which more or less corresponds to the ER low proliferation, have a very good prognosis. They are indolent, slower growing tumors that have excellent prognosis. The basal-like or the triple negative subgroup has the worst prognosis. I know that all of you are looking at this graph, which shows the HER2, but that used to have a poor prognosis earlier. This was a graph taken from 2003. But since the advent of trastuzumab, this line now lies somewhere here. So we have the luminal A, the luminal B, the HER2 now which lies somewhere in between, and the triple negatives at the bottom. And so therefore, by classifying in our mind which group the patient comes into, we are able to approach breast cancer. And since luminal A, B, and all that are things that are not designed in the clinic, we therefore depend heavily on the ER, the ER and its downstream, the ER and the PR pathway, the HER2, and along with that the KICC7, and then the triple negative. So with that basic understanding of the types of breast cancer, let's move into how we approach breast cancer in the clinic. So I have divided this into three parts: the early breast cancer, the locally advanced, and the metastatic. So the first thing we must understand is early breast cancer is a systemic disease. Now we know that because when it was believed to be a local disease, there was the Halsted type radical mastectomy. And despite having done such a radical surgery, the distal metastases were common. And so that led to the hypothesis that breast cancer must be spreading before the diagnosis. And therefore, if that is true, if it does spread before that, then you don't have to do such an extensive surgery. A less extensive surgery will be adequate if the local control is maintained. And that has subsequently been proven to be true. Then second hypothesis is that systemic therapy will be necessary. And so that is how the idea of using chemotherapy even for early breast cancer came about. And if systemic therapy is necessary, it doesn't matter whether you give it before surgery or after surgery, as long as the patient gets the systemic therapy. And that is that all of these hypotheses have subsequently been proven to be true. So I know this is a confusing slide. I've only put it up to show that the exact choice of systemic therapy is varied. There are so many choices, and therefore our choice is very individualized. It depends a lot on the patient. It depends a lot on what our outcomes are that we are trying to achieve. And so now, so going to systemic therapy, one thing we will understand is giving chemotherapy does improve survival, and that has been shown again and again and again. So you can see that from the very first types of chemotherapy, they showed an improvement in overall survival, and addition of taxanes has further improved the survival. So therefore, the sequential use of anthracyclines followed by taxanes is the current standard chemotherapy that we would use for all patients. And the indications for using this chemotherapy are in all HER2 positive patients, in all triple negative patients, and those who are luminal B-like, which means they are ER variable, they may be positive or negative, and they have high-risk features which tell me in the clinic that maybe they are luminal B and therefore require chemotherapy. That is, they have a grade 3 or high proliferation or a relatively low ER expression, and they may be node positive or high T stage. Okay. The advent of neoadjuvant chemotherapy, I'll talk about it a little later, but we do use neoadjuvant chemotherapy far more often nowadays, and we use it for any cancer which is triple negative, HER2 positive, anything that is more than stage 2, or if there is a large tumor in a small breast. These are the indications for when we would use neoadjuvant chemotherapy. Going on to early HER2 targeted chemotherapies, we know that trastuzumab and chemotherapy significantly impacted outcome. Adding trastuzumab to chemotherapy has been shown to improve survival in multiple trials. And we also know that adding a standard duration of maintenance therapy is also effective. And now this is standard therapy. Additionally, now we have certain other HER2 blocking agents which have come into the market, and they also improve the response rates and improve survivals when they are added to the standard trastuzumab therapy. I will talk about trastuzumab emtansine later on. So what do we do for hormone receptor positive early breast cancer? So let's say this is the common thing that happens for us in the clinic. We have a 46-year-old lady. She's come to us with a 2-centimeter lump in the breast for 3 months. She does not have any palpable nodes. A biopsy indicates that she has an invasive ductal carcinoma, which is ER positive. She is HER2 negative, and she has a moderately high proliferative index. So the question in my mind when she comes to me is, does this patient really need chemotherapy? Or in other words, is this patient a true luminal A breast cancer in which her benefit of chemotherapy is small and I could treat her with just hormone therapy? Or is she a luminal B-like breast cancer where chemotherapy would significantly improve her outcome? So how do we find the answer to this? Now, there are multiple, because this is a common problem, especially in the West, much more so than here, because a lot of patients do present early in breast cancer in Western countries. They have found an independent predictor of prognosis of recurrence beyond just the clinical factors that I mentioned earlier. So one of them is this recurrence score. So what they have done is this exact patient, if she came to the US, what would happen to her is they would take her biopsy block and run a 21 gene panel on it, which has already been shown to predict relapse. And so if the patient came under the low risk group here on that panel, then she doesn't need chemotherapy. She needs only hormone therapy. If she came as the high risk group, she definitely needs chemotherapy. Hormone therapy alone would be inadequate therapy. And intermediate also, she can receive only hormone therapy. Now, this is something that's available for, not available for patients in India because of its cost and difficulty in sending to the US. We do send on and off, but it's extremely expensive. But there are other online estimation tools which are available, which have their drawbacks, but that's another way for me to assess in the clinic. Who are the patients who are most likely to benefit from chemotherapy, and how do I choose that patient correctly? The third thing to remember is adjuvant tamoxifen prolongs survival in hormone receptor positive breast cancer. So that's an important takeaway. It's been shown in multiple trials that adjuvant tamoxifen improves their survival, decreases their mortality, decreases their recurrence rate, and improves mortality by age in almost all subgroups. And so therefore giving patients tamoxifen who are ER positive is essential. There is also data to say that for high-risk patients, extending that duration of tamoxifen to up to 10 years also may have a small additional benefit. Remember, this benefit is small, but we choose our patients carefully, but we can give for up to 10 years. So 5 years as a minimum, up to 10 years for patients who are high risk of relapse. Now moving on to locally advanced breast cancer. The purpose of neoadjuvant chemotherapy is what I'm addressing here. Now remember, in locally advanced breast cancer, it means that the patient has a relatively large tumor. Doing a surgery may be cosmetically unacceptable or may lead to the risk of inadequate surgical margins. So this is where using neoadjuvant chemotherapy for increasing the rate of local control and increasing rates of breast conservation are important. However, like I said, whether you give the chemo before or after surgery doesn't impact their survival. And the latest application of neoadjuvant chemotherapy is this. That is, by giving chemotherapy to a patient who comes to us initially, we give them all the chemotherapy that we want. And then at the end of surgery, we get the surgical pathology and we see how well our chemotherapy performed. So it's like an in vitro trial of chemotherapy. And by doing that, we are able to see who are the patients who have had adequate therapy and they have achieved a complete response, and therefore they are unlikely to relapse. Whereas those who do not achieve a complete response, it tells me that their tumor has a bad biology and they'll probably need more chemotherapy. So this sort of treatment tailoring is something that is an advantage that is given only through neoadjuvant chemotherapy and not through adjuvant chemotherapy. So here's the same thing that I said earlier. After giving neoadjuvant chemotherapy, if my patient achieves a complete response, that is no viable tumor on the surgical specimen, their chances of relapse are only, a 5-year chance of relapse is only 5 to 7%. Whereas if at the end of all my neoadjuvant chemotherapy, the patient continues to have residual disease in the surgical specimen, then their chance of relapse is almost 25 to 30%. And therefore, if I can find this information, I can choose to give more treatment to this group and therefore potentially prevent them from relapsing. This has already been studied in multiple, this idea of treating those who don't achieve PAT-CR has already been studied. So this is a study where they gave triple negative breast cancer patients chemotherapy, and those who had residual disease did not achieve a complete response were randomized to get further capecitabine chemotherapy, and they were able to show an improvement in disease-free survival. Sorry, this is the one. This is the CreateX trial. So sorry. They randomized patients at the end of chemotherapy to get capecitabine, and they were able to show an improvement in disease-free survival. Focus on this one here. Disease-free survival was improved in the patients who received further chemotherapy when they did not achieve a PAT-CR. This is a similar study done in HER2-positive breast cancers, where those who did not achieve PAT-CR were given a novel drug called TDM1, and again showed an improvement in survival. Now, what to do about metastatic breast cancer? I know that there is a tendency to think that once patients are metastatic, it's end game, and there's no point in treating them and all. That's definitely not true. The goals of treatment in metastatic breast cancer are different. Our goal is not cure, but we have to balance the efficacy of treatment versus toxicity. We try to improve survival. We definitely try to delay progression of treatment and prolong the duration of response. By giving chemo, we know that there is a lot of palliation of symptoms and maintain quality of life. But we have to choose the patient correctly, and that is where the art of choosing and looking at clinical trials and applying to the patient comes in. So we need to work as part of a multidisciplinary team with the palliative care team, with the radiation oncologist, all together to achieve that outcome that we want, which is improving quality of life and improving survival. So what do we do for metastatic ER-positive breast cancers? there are multiple targets available now. Okay, so it is not essential that these patients have to receive chemotherapy, but there are multiple targeted therapies available. Already, we have multiple trials with the CDK4 inhibitor group, which has replaced chemotherapy in many patients unless they develop organ failure, and has shown significant improvements in survival. And many more drugs in different pathways which are on the pipeline. So this is what I said earlier. The use of CDK4 and 6 inhibitors has gone from third line, second line, and now has reached first line metastatic treatments, and has shown significant improvements in survival, with improvements in quality of life because they're not exposed to chemotherapy. And the most exciting thing about these treatments is that the median time to progression in many of these patients was about 4 to 5 years, and their survivals were excessive of 7 and 8 years. So you're looking at drugs that are not toxic and can be taken for long periods of time and significantly improve their survival. Fulvestrant is also an option for those who don't have access to CDK inhibitors. It's still expensive in India, and so this is another drug that we use for such patients. For HER2 positive breast cancer, the number of options have been expanding. As you know, the use of trastuzumab significantly improved outcomes for HER2 positive breast cancer, and the use of trastuzumab resulted in longer overall survival, time to progression, and has become the standard of therapy for HER2 positive breast cancer in all lines. Now, the additional change in that is we also have a drug called pertuzumab, which prevents the dimerization of the HER2 receptor. And in addition to trastuzumab, as you can see, it binds in 2 different sites. Trastuzumab binds here, pertuzumab prevents the dimerization. The combination of the two has been shown to improve their outcomes. This is the study that added pertuzumab to standard therapy, and they were able to show an improvement in disease-free survival. And so now we look forward to many more drugs that come. Each group of this heterogeneous group of populations has new drugs coming up, which potentially can impact them. We have many new novel HER2 targeted therapies which are coming in. We have many novel targeted agents which are available. We also have many new antibody drug conjugates which are also coming in, which are being used with very exciting effects in all the trials that we have seen so far. And of course, I'm not even talking about immunotherapy, which has not been as beneficial in breast cancer as we would have hoped, but there are a lot of immunomodulatory things that we can do to improve their efficacy and the outcomes in these patients. So my take home is we have to be careful always when we see a patient to choose the right drug for the right patient in the right dose through the right route to be given at the right time. And by doing all these things, we can improve the outcomes for all our patients. Thank you.
Thank you, Dr. Ajoy. Any questions, please feel free to ask, sir. Lecture will soon be uploaded, and can either mail the doubts also to Dr. Ajoy. If no doubts, Dr. Ajoy, I think I will wind up. Any further comments, please do feel free to mail to Dr. Ajoy. Thank you.
Thank you.